So why don't we get started? Welcome, everybody. Just a bit of housekeeping to start. During the seminar, the chat function on Zoom will be used for attendees to say hello, as you're doing right now. But please direct questions using the Q&A function. And also please use the like function for questions you see in the Q&A section, which will help us prioritize questions to be asked to our panel. The seminar is being recorded and will be available on the Epidemic Ethics website later in the week. The seminar is also being live streamed to the Global Health Network's Facebook page, and a recording will be available there too. I'm Adrian Viens. I'm the inaugural director of the School of Global Health at York University in Canada and the York Research Chair in Population Health Ethics and Law. My research focuses on global health ethics and global health law, with particular interest in demonstrating how philosophical analysis, legal epidemiology, and regulatory theory should shape how we approach different issues within global health policy, practice, and research, especially with pandemics. Epidemics and pandemics represent collective threats to humanity's health and well-being. Effective and equitable responses to epidemics and pandemics arguably require collective action. Collective action is also arguably needed to address some of the causes of epidemics and pandemics, such as climate change. In practice, responding to collective threats can be challenging due to conflicts that can arise between individual and collective interests. When collective action is at the local, national, or international levels, it may make individuals, organizations, or governments better off, but they may fail to cooperate because of their individual interests, discouraging cooperative action. The seminar will present the first in a series of focused on academics and collective action, and will examine the nature and role of individual and collective responsibility in relation to epidemics and begin to consider how ethics can help provide a framework for promoting collective action. So I'd like to take the opportunity to introduce and welcome our distinguished panel. We have Dr. Caesar Atuire, who is the ethics lead for the MSc in International Health and Tropical Medicine at the University of Oxford, an associate professor of applied philosophy in the Department of Philosophy and Classics at the University of Ghana. He obtained his PhD in philosophy in 2005 and holds a master's degree in theology and diplomas in bioethics and pedagogical sciences. Caesar works around revisiting some of the underlying conceptual frameworks informing bioethics, and by drawing on philosophical ideas, African and non-African, that address inequity in the relationships that govern current approaches to global health with an eye to new ethical frontiers, decolonization, and pluriversality. We have Professor Daniel Goldberg, who's a trained attorney, historian of medicine, and public health ethicist. His current research agenda in law, policy, and bioethics focuses on the social determinants of health, public health policy, and chronic illness and health inequities and stigma. In addition to this, he maintains an active research program in the history of medicine and focuses primarily on two topics in 19th century America: the history of medical imaging, especially X-rays, and the history of pain without lesions. His doctoral dissertation addressed the underlying treatment of pain in the United States. The undertreatment of pain in the United States, and has been actively writing, teaching, and speaking on the subject of chronic pain since 2000. Professor Sir Nicholas J. White is professor of tropical medicine at the University of Oxford and at Mahidol University in Thailand. His diverse interests include epidemiology, pathophysiology, management of uncomplicated and severe malaria, melioidosis, enteric fever, tetanus, dengue hemorrhagic fever, Japanese encephalitis, and tuberculosis. His particular interests at present include the pathophysiology and treatment of severe malaria, prevention of anti-malarial drug resistance, including artemisinin-based combinations, and the biology of vivax malaria. We also have Professor Vijay Kumar Yadavendu, who teaches in the Department of Psychology at Patliputra University in India. He obtained his PhD in public health in 2002 from Jawaharlal Nehru University and the University, in New Delhi in India. He writes on philosophical historiography of public health and public health issues. He's published many articles in journals and is the author of Shifting Paradigms in Public Health, From Holism to Individualism, published by Springer in 2013, as well as a forthcoming volume entitled Drugs, Pills, and Power: Contestations and Conjectures, published by Routledge. In terms of the structure of our time together here, each panelist will provide a short introductory remark of about 5 minutes or so. Then we'll have a panel discussion, follow addressing key seminar questions, as well as questions submitted by you, the attendees. So Caesar, would you like to please start us off?
Well, thank you very much. Really honored to be here. And I'll start off by sharing my slides. Yeah. Are they visible?
Yes.
Great. So I'm going to start off by sort of like looking at the conceptual level of the issues we're dealing with regard to collective threats, collective actions, and collective interests in dealing with pandemics and disease. And the first claim I would like to make is that I think there is something flawed or inadequate in our way of actually thinking around our ethical commitments. Most of the ethical frameworks we use today stem from historical facts of trying to resist forms of paternalism, totalitarianism, and therefore we have ethical frameworks that insist a lot on the individual entitlements. And these individual entitlements, taken to a certain point, enter into conflict with our community obligations. Now, if we want to think about ethics seriously, one question we may need to ask ourselves is, if we were living alone on this planet, would we need ethics? So as soon as we begin to think about ethics, we have to realize that there is an altruistic dimension to any ethical commitment. It is because we are bound and we live with other people that we need ethics. And therefore, any ethical framework that does not underline this particular altruistic commitment as part of the basic ethical commitment is a flawed concept. Unfortunately, most of the concepts we use in ethics, in global health, tend to insist a lot on our individual entitlement. So you come across even research ethics committee members, and you ask them, what do you guys do? Oh, we're there to protect people from our research participants from not being abused. But they are not there even to ask about why should people be abusing research participants in the first place anyway. So the second point I want to make is the title of this webinar repeats the term collective threats, collective interests, and collective actions. Collective perhaps is not even the right term to capture what we have at hand. These are not accidental agglomerations whereby anybody can bow out at any time. The threats we're facing are such that as long as we continue to inhabit, all of us, planet Earth, no one can escape from them. Threats linked to climate change, threats linked to pandemics. So it is not just an occasional, transient collectivity that we're dealing with. Here we're dealing with a permanent condition of shared vulnerability. And therefore, the approach to a problem that is shared and that is permanent and increasing requires a consistent normative approach that takes into account the fact that this is something that affects us all, and that no one can be an individual winner in this game. If I may use an example maybe from collective sports. If you play in a team, you can score many goals, but if your team loses, you have lost. The third point is healthcare. There is a white elephant in the room when we begin to talk about healthcare. If health is a basic or one of the fundamental or primordial needs to be able to enjoy other goods on earth, why have we handed healthcare so much to private interests? There are other goods that we share, water, for example, in many of our countries, or electricity, which are shared goods, and we realize that they are necessary for our living. We tend to manage them in a collective way. And therefore, even a private water supplier in the country cannot just decide to apply any price to the water that they actually feed into people's homes. Yet in healthcare, we have allowed a great deal of private interests that are uncontrolled and unbridled. So this leads me to the next slide, since I have only 5 minutes. We can take two ways to approach this, but I think it is not an either or, it is an et. So should we go for a radical change, or should we look for incremental change? Now, radical change is what the impatient dimension of our beings usually ask for. And unfortunately, when structures are not present, radical changes tend to reflect this phrase from Il Gatto Pardo di Tommaso di Lampedusa, which says, bisogna cambiare tutto affinché nulla cambi. So we need to change everything so that nothing will change. And that tends to happen if structures are not in place and you want to create a radical change, you actually end up sometimes not achieving what you want. And we've seen that even in the recent decades of some revolutions that have taken place in certain countries, that today, at a distance of about 6 or 7 years, everything is returned back to normal. So while we're looking for a radical change to begin to think about health care as a common good, we also need to start working on the incremental change. And there are two principles that I think are very important here. And later on, perhaps in the chat, we can illustrate them. One is solidarity, which should not be conceived just as an axiological concept, whereby it is something that nice people do. No, solidarity is what decent human beings practice. It is not a supererogatory concept. It is a normative concept of people who realize that their destinies are linked together. Secondly, we need a principle of subsidiarity. One of the great problems of inequity is the colonial inheritance that we have in this world. And the main problem of coloniality, and not colonialism, I mean coloniality, is the subtraction of agency. Therefore, the principle of subsidiarity says, let us return agency to where it belongs. Translated into pandemics, it simply means, let us ensure that the local organizations that are closest to the problems are empowered enough to be able to start addressing them with an eye to justice. And therefore, we should not continue to silence their capacities, but rather look for ways of collaborating with these local capacities in order to be able to find collective solutions. I think my 5 minutes are up. If there are more concrete questions, I'll answer them during the Q&A. Thank you.
Great, thank you very much. We'll move to Daniel next.
So thanks, everyone. It's a privilege and an honor to be here. So I thought really the one thing I wanted to talk about in context of collective action is something I've explored in a little bit of my work, which I refer to as methodological individualism. We see this in public health, we see this in global health, and I think this actually tracks pretty well with Dr. Atuire's point about the inadequacy of some of our ethical commitments. He said they tend to focus in this sort of atomistic, almost individualized way. And that's what we see a lot in public and population health. This is especially true in the US, I think, and North America, but partly because of those processes of colonialism and imperialism, we have also seen this sort of imported into a global health context as well. So there's lots of different ways of defining and thinking about methodological individualism in public and population health work, in global health work. But as a shorthand, I think one of the most convenient ways of thinking about it is that the individual is positioned as the unit of change, right? So whatever kind of public or population health intervention we use, the individual is sort of the agent of change. Whatever change is going to happen in the world, the intervention sort of tends to presume or behave or act or be targeted at individuals as the unit of change. This seems confusing, right? Because of course, all populations and publics are composed of individuals. So how else would it work? And I'll give some examples of that. But the easiest way of thinking about it is, of course, one of the things we know in public health ethics and in global health ethics in general is that we can't understand the properties of groups and communities solely by aggregating them into the behaviors of the individuals that make them up, right? That gets us into what's referred to as the fallacy of division or the fallacy of composition. Groups behave differently even though they are composed of individuals, and we cannot understand the behavior of those groups and communities nor design interventions solely by aggregating them into the behaviors of those individuals, right? So, the classic example I give in the US is one of the things we did earlier on in the pandemic is we asked people to avoid high-risk scenarios in many places in the US, right? So in the COVID-19 pandemic, we asked people early on in the pandemic, for example, not to go to crowded bars and nightclubs, right? And so there were sort of depending on the individual to make a decision that will result in changes for everybody, right? So that's methodological individualism, because another way of proceeding is to actually close bars and clubs temporarily, right? That's more of a structural intervention because it doesn't really depend so much on the individual decision as to whether or not to go to those kinds of things, right, and engage in those kinds of risks and then to expose others to risks, right? But it's more of a structural change. So there's three problems with this methodological individualism in public health, and there's a lot of examples how, especially in the US, but I think also we can see this in global health context, that this kind of methodological individualism is rampant, right? And it's probably rampant because it's low-hanging fruit. Structural level interventions are harder to implement, especially with force of law as well, than these kinds of individualized interventions. But there's three central deficiencies. The first is that they tend not to work very well, right? So we end up expending scarce resources on low-yield interventions. And for anybody who's thought for a moment about, sort of principles of justice, especially distributive justice, right, that's not going to work very well, right, to do that. So we ought not expend scarce resources on low-yield interventions when we could expend those resources elsewhere on higher-yield interventions, right? Methodological individualism has also often been referred to as agentic. That's one of the words that's been used for that in the epidemiology. And agentic interventions tend to depend on the individual resources that agent can bring to bear for any effects that they actually have. So they don't tend to have a lot of really sort of positive effects. To the extent they have positive effects, it's actually only the more affluent communities, right? And this is true globally. We see this, of course, right? As well as in hyperlocal, so sort of at all levels, which is common with social determinants of health, which means that these methodologically individualist public health interventions that we see in pandemics and in other kinds of population health practice, they actually tend to expand health inequities, right? So they don't work very well. To the extent they work at all, what the effect, the most likely effect that they have is that the very affluent, or the most well-off, are most likely to capture sort of whatever benefit actually flows from these kinds of interventions. So they tend to expand health inequities, and that's a problem. Then the third sort of central deficiency as a threat to sort of collective action in public health is that they tend to intensify stigma. To Dr. Atuire's point, right, that ethics is about the fact that we live in community with each other, right? We aren't atomistic individuals, right? But unfortunately, methodological individualism, one of the reasons that I and others suspect that it's popular is because it puts an emphasis on individual rather than collective responsibility to respond to these kinds of public and population health threats. And we know, because we have very good evidence for this, that when we emphasize individual responsibility for public and population health concerns, that has the marked tendency to intensify stigma, right? And stigma is a creature of inequality to begin with. So we see sort of equity and justice-based concerns flowing through all three of these central deficiencies of methodological individualism, right? So to me, that's one of the most significant threats that I see to collective action in public health. And you can see that in my country, in the US, sort of locally, regionally, nationally, but I think we can also see it in the international political order as well. And so I think that this is one of the things that we should probably address. So I'll stop there.
Wonderful, thank you. Why don't we next move to Nicholas?
Thank you very much. I hope you can hear me clearly. Just to give you a perspective of where I'm coming from, I'm a medical doctor, a clinical researcher. I live and work in Southeast Asia and have been conducting research on a variety of nasty infectious diseases for many years, and probably was invited to this seminar because I've been spending a lot of time recently conducting trials of the prevention and treatment of COVID-19. I also chair the COVID-19 Clinical Research Coalition, which is an open coalition which has tried to facilitate the conduct of research on COVID-19 in low-resource settings to try and remove try and reduce many of the obstacles to conducting that research. So I've only got one slide, and it's from the perspective of a clinician conducting research in low-resource settings. So the first thing to say about epidemics and pandemics is that they're going to keep happening. We're probably not going to have one, or we hope we won't have one as bad as the one that we've just experienced, which had a seismic effect on society throughout the world, but we're certainly going to have more. We will certainly have flu, and let's hope that that flu doesn't kill millions, which it could do. But they are a constant threat, but they create an unusual environment, a more stressful environment, a more socially disruptive environment than most other medical threats. Everything I'm going to say is not going to be a surprise to you. So the first thing is that they don't gain attention and money when they don't affect or pose a threat to wealthier countries. They can still, of course, cause morbidity and mortality, but that doesn't seem to get the attention that it does if it poses a threat to wealthy countries. At a more provincial or parochial level, you see much more attention given to infectious disease threats when they affect cities rather than rural areas, because cities are where the power, the money, the journalists, the advocates live. Unsurprisingly, in COVID, political and national considerations dominated. This should not be a surprise to us. I mean, politicians' job primarily is for national interest, but it certainly distorted the necessary research that was required to address COVID. Overall, research in COVID was a bit of a mixed bag, a curate's egg. We were very successful. I say that the research environment, or the researchers are very successful in producing vaccines, and the vaccines that resulted were better than had been hoped for. At the beginning of the pandemic, WHO would have certainly accepted a 30% efficacy, and we got 90%. So we were very lucky there. The rest did not go so well, particularly in the area of diagnostics and therapeutics. Research was very poorly coordinated, poorly led, and it resulted in a very large number of small trials, which were insufficiently powered and to answer any questions, effectively a waste. The funders spoke big, but actually were very slow, and often, despite promising very large amounts of money, it did not emerge, and it was not distributed equitably. So there's a lot of talk and not so much do on the funding side. And in this vacuum, researchers did what they always do, which is to act in their own interests. Hence the very large number of small ineffectual clinical trials and clinical investigations, and a lot of information of low quality, which was published simply because it had the word COVID in it. Some of it was misleading, and it all contributed to the concern that the public had across the world. Journalists picked up any strand of information, be it good or bad, amplified it, and created a lot of confusion. We all experienced that. So researchers act in their own interest usually, but industry always acts in its own interest. Again, this is not a surprise to any of us. So various aspects of the pharmaceutical industry did extremely well out of COVID. Pfizer, which is the largest drug company in the world, doubled in size as a result of COVID. It contributed to a very, very effective vaccine and probably the best drug. But none of the pharmaceutical companies were willing, or very few of them were willing to provide any of their interventions for objective evaluation. And so we had a situation where countries spent enormous amounts of money on monoclonal antibodies, drugs, and vaccines, often spending a very large proportion of the available health budget without having the objective evaluations that would usually be required, so that you could say, is this drug better than that drug, and so forth. So I don't think that worked very well either. And just the obvious point to finish with, which I think was epitomized in sort of early 2020, and that is that when there is public concern, objective assessment is compromised. So lots of research was stopped simply because of public pressure, journalistic pressure, and sometimes agencies which should be independent, such as regulatory agencies, bowed under political pressure and made judgments which I think in hindsight they probably regretted. All this slowed down the necessary research that was required to answer the critical questions. So actually, overall, I don't think we did very well in COVID, and perhaps we will have further discussion as to why that was. Thank you very much.
Great, wonderful. And I want to move to Vijay.
Thank you very much for the opportunity. I'm very glad to be here. Actually, when we talk about the collective traits, if we see 21st century, we have many outbreaks of infectious diseases, and COVID is probably one of the biggest. And it was identified in December 2019 in Wuhan, China. Exactly 3 years back, WHO declared it as a global pandemic on 11th March 2020. At that time, the reported cases were 120,000 and the deaths were less than 5,000 worldwide. Almost 221 countries and territories were in grip of this deadly spillover infection, and official death is 6.9 million, but at best of estimate is of 21 million, that is almost thrice. In the ongoing pandemic, tens of millions continue to suffer from a vast array of symptoms grouped under the name of long COVID. The world lives in the throes of a colossal public health crisis and market failure. And I think it is a complex ecosystem which provide an opportunity for the epidemic, and that is natural and social and environmental factors. I think this pandemic has exposed the demagogy and incompetence of populists and taught the benefit of professionalism and expertise, as Fukuyama has said. Unfortunately, even today, infectious diseases kill millions, mostly infant and children worldwide. The infectious diseases keep revisiting to expose the global widening economic and health inequalities. An estimated 5.6 million people die every year for lack of access to healthcare in poor countries. And with the financialization of everything, the citizens have become consumers. This effectively forfeits the dynamics of interaction between the individual and his environment with its consequent impact on health. This is unprecedented that almost half of the humanity was in draconian lockdown and in totalitarian surveillance. ILO has cautioned that full or partial lockdown measures are affecting almost 1.6 billion workers out of the total estimated global workforce of 3.3 billion. The global unemployment is projected to remain very higher than in 2019. At that level, it was 186 million, and now it is almost 203 million. I think in the time of contagion, a biopolitical strategy becomes a tool of the state for intensification of surveillance, intervention, subjugation, segregation, and control over bodies and population. And globally, and particularly where democracy is not deep-rooted, it has been seen throughout. India is also a very good example how stigmatization has been, certain community has been stigmatized. And in all this process, it is impressed upon the individual mind that the solution is locked within the expropriation of personal genetic data, drugs, and pills available in the market at certain price, or in some forms of mass surveillance, confinement, exclusion, behavior modification, and control. Behavior modification, along with clinical medicine and genetic decoding of disease, become the guiding principles of public health that do not add meat of social and economic inferences on choice of occupation, personal hygiene, lifestyle, sanitary conditions, and a range of other factors that affect health and which remain outside the control of the individual. Such kind of prescription serves two purposes. The collective is robbed of the power of effective intervention. And the second, it gives a rise of a booming pharmaceutical industry and medicine. It helps to breed and sustain the attitude that problems are to be solved by some form of technological effects or by alteration in individual behavior, instead of by broader and more societal changes, which may challenge the position of the dominant in society. But the individual maximization of private profit necessarily endangers the public good. Health matters are entrenched in the market forces to be bought and sold according to the capabilities and capacity of the individual consumer patients. And this is so true of the ongoing pandemic, where neoliberal capitalism has converted public services into commodities to be bought and sold in the market. Even a global pandemic becomes an opportunity for entrepreneurs to find ways for production, marketing, and maximum private profit. Oxfam has reported that during the COVID, 2.7 billion a day was actually since the pandemic began, collectively increasing their wealth by 26 trillion since 2020. The crisis of COVID-19 is symptomatic outcome of bantam human greed and environmental and climatic devastation of the hegemonic neoliberal capitalism. The world lives in the chaos with the collapse of infrastructure, a plummeting rate of growth in economy, declining life expectancy, heightened inequality, exploitation and violence, and a deep sense of despair and distress. There is an urgent need for a radical reconstruction of the world over beyond unbridled manic consumerism and maximal private profit. We hope that COVID-19 will restore the fundamental epidemiological common of human ethos of equality, justice, and fraternity, where humans are not seen just as autonomous, discrete, self-seeking, atomized individuals. And so it is very important to understand the very orientation, how public health is losing grip over its own science and history. And I would like to end with the optimism that a better world will emerge after this pandemic. We must embrace and nourish the feeling of humanity and solidarity endangered by the current moment, as Pamuk has said. Thank you very much.
Right. Thank you very much. All right, so we'll now proceed to the panel discussion, where we're going to address some of the seminar's key questions. And I'll remind our panelists of the following. It's, what are collective action problems? What challenges do collective action problems pose for pandemic preparedness, prevention, and response? What solutions exist to collective action problems? How might conflicts between individual and collective interests be resolved in epidemics and pandemics? And what role might ethics play in helping to develop appropriate responses for the collective action problems that epidemics and pandemics create? We also had a few registrar questions before. So questions about, what is the role of the United Nations in ensuring collaboration between rich and poor countries? How might we integrate ethics in settings of limited resources and limited knowledge among people whom content is a challenge to obtain? How can we consider lethargic leadership in some countries as a threat, especially when governments might have to wait for initiatives from elsewhere? And finally, what could be done to change the mindset of many developing country citizens who claim vaccines are a trap to depopulate them and kill them in the future? Also for present attendees, again, please do use the Q&A function to place some questions, as well as to use the like function to help us prioritize questions. And so I'll open it up to the panel in relation to both those questions to structure the seminar, as well as some of the questions that we got from people who registered for the seminar. So throwing it open.
Well, do we just take the questions randomly? Because there are quite
randomly, when we think there's interest, and we'll just bounce off.
Packed in there has a number of questions. Well, the first question I think was referred to the United Nations. Well, the very structure of the United Nations, historically and even constitutionally, is a little bit problematic. Because, I mean, this is a union of sovereign states. I mean, it's sovereign states coming together. Government, the principle of sovereignty is very strong within any UN structure. And because of that, I mean, there is an exaggerated principle whereby we saw, I mean, during the COVID-19 pandemic, countries practicing vaccine nationalism and all that. And somehow we need to be able to tone this down. That is one. Yet the other thing is, it is the only organization that we have at the moment that actually brings together all the countries. So that is why we have to go into these structures and see how we can create mechanisms to make countries more accountable to each other when we're dealing with problems that we share globally. Then the second point, as I mean, with regard to helping poor countries, yes, I mean, you know, I would even say the first ethical principle really is not to do harm. Primum est non nocere. The thing is that the behavior of certain high-income countries was actually harmful. So we're not even just asking for help. We're asking them to stop harming. When you pre-purchase and you block the opportunities of other countries from having access to vital, I mean, health goods, you are actually harming. So that is one. And then secondly, the idea of actually helping, let's also be a little bit clear about that. You know, what type of help? What type of help? Because some forms of help can become another form of colonization that keeps killing the agency of countries, and even to some extent allows leaders of low and middle income countries to sort of abdicate from their responsibilities of helping their own people, because they also have to be engaged. And so it's a question of, that's why I brought in the principle of subsidiarity, that everybody has to do what they have to do according to the power they have. But anyway, I'll leave the other questions. I don't want to monopolize the conversation. Thanks.
Yeah, please, Nicholas, go ahead.
Thanks. I think that one of the problems that was exemplified by COVID was that in the intense concern that was created early in 2020, collective action was compromised. The usual approach to a less aggressive and a less urgent threat would be through the usual channels of discussion, evaluation of available evidence, and so forth. But I don't think that the United Nations was strong enough at that stage to trump, apologies for the pun, national priorities. And thus the rich and the powerful countries did what they felt they had to do, which was grab as much of the vaccines and then subsequently drugs as they could. And then, you know, the less wealthy countries were left to receive those vaccines, if they got them at all, much later. In fact, their main immunization was by catching the virus. So very simple. I don't think that in the heat of battle, you're going to get an ethical solution. So let's make one while the battle is cold. Let's do it in the peacetime through whatever negotiating mechanisms are appropriate, treaties or whatever. Create mechanisms that would facilitate ethical activities during times of intense stress. Over.
What do people think in terms of, we talk often about collectivity, collaboration, coordination. Caesar talked about, we have existing structures. Instead of trying to reinvent, do we try to go through our current mechanisms and the WHO? Even in trying to organize and try to negotiate this in an antecedent fashion, do we think that that is going to be possible given the unequal structures and power distributions? Do we think it's going to have a better chance, even in times between pandemics, of trying to get countries, high-income countries, again, abdicating in some way or reducing their own best interests, right? Of course, that happened in a bad way during the pandemic. Should we have any optimism it'll be any better, even outside of that? Nicholas.
I want to hold the discussion, but just raise a scientific point here. One thing that hasn't been done sufficiently is to impress upon everybody in the world, but in particular those with greater resources, that actually it's in their interest to act globally rather than parochially, regionally, nationally, or whatever. Pandemics don't respect national borders. Epidemics sometimes do, but pandemics don't. You can't hide yourself away. No one could. Almost no country, well, no country was able to prevent COVID coming to it. It originated in one part of the world, it came to another. We need global solutions, but we don't do well, or we did not do well during COVID in providing those global solutions equitably. So I think we should try and forge them now that the pressure is down. I'm not saying COVID's gone away, it hasn't. It could easily come back with a sting in the tail. Could be something else coming, but it's likely that things will be quiet for a year or so. Let's try and figure it out now, and let's create a better situation and anticipate the next one, and make our response to, our collective response to the next one better than we did last time. We did not do well, in my opinion, in COVID. Over.
So what do people think? Yes, Cesar.
Yeah, just to add to that, I think maybe even our the people who are part of this webinar have seen that the zero draft of the new pandemic treaty is out. And I think to some extent, that is what Nick is talking about, using this particular period to create a document. Now, that document is trying to set up a framework for addressing future pandemics. It won't be perfect. It has to go through several iterations, but I think that is a step in the right direction. The only problem with documents like that is, how do we ensure that even once this document has passed through the WHO General Assembly and has been signed, we don't have a case of a country just like sending a letter to say that, oh, I'm bowing out of the WHO during at the height of a pandemic. And we saw that happen. So we need to create mechanisms even to be able to sanction such behavior. And this is when we're going to ask the same people who might do that to sign the treaty. And that's where the difficulty is going to be.
The thing, right? If you noticed, a lot of the language that we had around equity, people talking about all these facilities, we should be in a good place. And we saw, even with those commitments, even with that language, it didn't pay off at all. And so I guess the worry is, again, whether through different legal mechanisms, whether there's a role of ethics, how do we, again, build in either conditions about enforceability or other ways ensuring of accountability? Anybody else? It was Vijay or Daniel on some of these questions.
Hello. I think it's not, the world has not to run by compassion, and, a very notion of help is very problematic. And if we see the larger context, how the pandemic has become opportunity for a very small section of society, and the larger concern of collectivity and their health was become an opportunity for, minting money. This is a very serious kind of a problem. It leads to, it is almost the way the world is. Inequality, that is a very systemic violence against certain class of people. So it has to be, and there has to be rethought how to redo it, because in my opinion, it's very difficult, because when the way in all 3 years, millions of people lost job. They were not having, I will take the example of India. When the lockdown was announced, it was announced very suddenly, and millions of people marched on their feet to their places. It was chaos kind of a situation. So there was not preparation, and it has been, used, as I have said earlier, used against certain community to vilify them. So there has to be a serious thought, and public health in very particular has to return back to science, not scientism, and it has to go back to its history for a more just and equitable distribution of health services.
Yeah, Daniel.
Yeah, just to track some of the comments, I think the other point that I sort of wanted to raise, and this is reflected in some of the Q&A also, questions about sort of vaccine hesitancy, tracking vaccine nationalism, and sort of picking up on Professor Yadavendu's point is, to me as a historian, I think about the histories of structural violence in differentiating between something we talk about quite a bit in ethics, which is distinctions between trust and trustworthiness. I think we've spent too much time in global health and population health contexts asking why certain communities don't trust high-income countries, why they don't trust pharmaceutical companies and stuff like this. And the COVID-19 pandemic was a perfect example, as Dr. Atuire has talked about, right, of why it's really not about trust, it's about trustworthiness, right? And the fact is that high-income countries, Western nations, weird countries, right, Western educated, industrial, rich, ostensibly democratic, in quotes, I'll put it, right? We are not seen as trustworthy actors, right? And that is just perpetuated over and over again. And that's, again, something we saw through this lack of solidarity in the pandemic. So to me, the question really isn't, how can we build trust, right, between high-income nations and lower middle-income countries in particular, but it's really about, given these histories of structural violence and colonialism and racism in particular, right, it's really what can the sort of wealthy and empowered actors do to become trustworthy actors, right? And that's really, I think, one of the biggest collective action threats in the world is, for very good reasons, high-income countries, sort of multinational corporations like this are not trustworthy. And that's correct, right? I mean, we have not become trustworthy actors. And so to me, that's part of how do we respond to these kinds of collective action threats moving forward is, not asking what has to be done to generate more trust, but really, what are the kinds of things, the agency to sort of put Dr. Atuire's point right to it. It's not just about making sure that sort of countries which have borne the brunt of colonialism and structural violence are granted the agency that they possess, right? But also that those empowered and wealthy actors and high-income countries, which have historically enjoyed most of the power, are doing what they need to do to be seen as more trustworthy actors in response to sort of collective threats. And I think that will be a sort of a critical thing going forward, which was a marked failure, perhaps not surprising, but really a marked failure during the COVID-19 pandemic.
What role do we think maybe ethics might play in that, even from the international level to the national level, and just picking up on some of the things Daniel talked about? What kind of drivers may be pushed, or what role might ethics play at that country level in trying to encourage these countries to become more trustworthy? Do we think ethics has a role in that? Or again, is it going to be coming down to the political and economic background conditions? Lazar.
Yeah, just your question brings to mind a point that was raised at the WHO Ethics Summit in December 2021. Interestingly, there were people from the United States, from the United Kingdom, from various countries across the world. And one of the things that emerged was that at the beginning of the pandemic, the committees that were set up to actually advise national governments hardly contained ethicists. So how can we bring ethical considerations onto the table right from the beginning when we are about to, implement policies? That is one thing I think that is important, to have ethics as part of the considerations. Secondly, there is something that I would say, I call it, almost dédouanement in French, like take ethics out of the customs area. And ethicists and scientists need to talk a lot together. Nick mentioned that, he's chairman of the COVID-19 Research Coalition. That was a group that tried to have even an ethics working group along with other scientific groups. The idea is that these problems that we're facing, especially with pandemics, are not just problems of pathogens or viruses, but they are also problems of livelihoods. And therefore, we need to have that broader conversation in order to be able to tackle them well. And then finally, since most of us are all in the field of, education, to remember that, teaching ethics across all disciplines in our universities should not be an optional. Over.
Nicholas.
Thanks. I do agree there should be an ethics dimension to almost all of the activities that we've been discussing. My particular area of research, we did not know how to contain the COVID-19 pandemic. We did not understand the epidemiology. We didn't understand the transmission dynamics. We didn't have any vaccines or drugs at the beginning. So there was a lot of information that was needed as quickly as could be possibly gained. We were not going to develop, the drugs and the vaccines were going to come from the high-income countries. That's absolutely clear. So there were questions about how any country could contain it and when would the products of the research become available to equitably to the people who needed it. And I think for all of those, science needed to be protected. Science wasn't protected, actually, it didn't do very well. It was distorted. It didn't go as quickly as possible. It wasn't funded appropriately and so on. And I think that all of that is effectively unethical. And how did we let that happen? Well, you could excuse it in saying, well, the political pressures were too great. But I do think that we should consider how good science, which means ethical science, can be protected under times of duress. And COVID was perhaps the greatest duress, but then war and other disasters also damage our ability to respond. So for me, I completely agree there is an ethical dimension to all this, but as a researcher, perhaps my vested interest is in trying to get things done as quickly as possible and to translate that as effectively as possible. That means that all agencies need evidence, and that evidence needs to be gathered as quickly and effectively as possible. How do we make that happen? Over.
We see in the Q&A, we saw from Adolf has talked about the tension and the conflict between individual and collective interests, either in terms of people waiting to see what everybody else does and delaying those choices, or when push comes to shove, the choice for self-preservation being the one that takes over. We seem to be, we make this mistake repeatedly looking through history. We think we've learned that lesson. We think we won't do that again. What do we think may be a solution to some of these kind of collective action problems where we don't seem to be learning lessons from history? Given powerful entrenched interests in high-income countries, looking at things like the corporate determinants of health, Might we think, even though, as Nicholas said, it's of course within their interest to be able to prioritize this and to be able to have a one of equity and ensuring that everybody is able to both detect and respond to these threats. But again, we seem to fail to learn this lesson. Might we think there's anything in terms of solutions that could try to finally lead us towards not repeating this mistake in future? Simple question to end.
Well, I think if there were a simple answer, maybe humanity would have found it by now and we wouldn't be asking this question. But honestly, sometimes it takes, a couple of real disasters for countries and communities to wake up. And we are now facing certain future, disasters, climate change, emerging diseases, war. And I'm just hoping that all this would help us to be able to wake up to the challenge that we have in front of us. As this writer, from the Czech Republic, Jan Potalska, who talks about a solidarity of the shaken. Maybe we need to experience, and I hope we don't have to experience very disastrous, events, but to become aware of the risks that we face if we do not stand together. Some of the problems will never be solved, and we will continuously be fighting to emerge from these threats. And I think that is the only way. And then, to keep working, especially in education with the younger generations.
Thank you. I think that's a perfect way to end. So I want to end, our time is almost up, to thank very much both the panel and for those of you in attendance, as well as to Adam at the Global Health Network and Kevin at Epidemic Ethics for both their organization and support of the seminar. As a reminder, a recording of the seminar is going to be available later in the week on the Epidemic Ethics website, as well as the Global Health Network's Facebook page. Please also check the Epidemic Ethics website for future seminars, and you can also follow them on Twitter, LinkedIn, and Instagram. So again, thank you to everybody. Goodbye, and keep well.